A headache that is already present when you open your eyes can make the entire day feel uncertain. You may blame your pillow, dehydration, sinus pressure, stress, blood pressure, or simply getting older. But when morning headaches repeatedly appear alongside disturbed sleep, loud snoring, breathing pauses, daytime exhaustion, or frequent nighttime urination, it is worth asking whether obstructive sleep apnea could be contributing. The important word is could. Morning headaches have many possible causes. Research does not support treating every waking headache as evidence of sleep apnea. In fact, a systematic review found that headaches were fairly common among people with obstructive sleep apnea, but sleep apnea did not clearly increase overall headache risk compared with people without the condition. A headache becomes more useful as a clue when it forms part of a wider pattern. Before we examine that pattern, there is an important safety boundary. A sudden, extremely severe headache, especially one accompanied by weakness, facial drooping, trouble speaking, confusion, loss of balance, or a change in vision, requires emergency assessment. Those can be warning signs of a stroke or another urgent problem. A new headache with scalp tenderness, pain in the temple, jaw pain while chewing, or visual symptoms also deserves urgent medical attention, particularly after age 50, because temporal arteritis can threaten vision if treatment is delayed. This video is about recurring, non-emergency symptoms that should be discussed with a qualified healthcare professional. It cannot determine whether you have sleep apnea, and no symptom checklist can replace a proper sleep evaluation. We are going to examine 6 signs, beginning with the headache pattern itself. Then we will look at the distinction many people miss: why you can have sleep apnea without being obviously sleepy, without having obesity, and sometimes without anyone reporting dramatic snoring. Why sleep apnea can become more relevant. After 60, obstructive sleep apnea occurs when the upper airway repeatedly narrows or closes during sleep. Airflow is reduced or briefly stopped even though the body is still trying to breathe. The brain then partially wakes the person to restore airflow. These interruptions may be so brief that you do not remember them, but if they happen repeatedly, sleep can become fragmented. Oxygen levels may also fall and rise throughout the night depending on the severity and type of breathing disturbance. Age does not automatically cause sleep apnea, but the risk increases as we grow older. Changes in muscle tone, body composition, the tissues around the neck and tongue, medical conditions, and medication use may all affect nighttime breathing. Heart failure, kidney failure, stroke history, alcohol use, smoking, anatomical airway narrowing, and long-term opioid use may also influence risk or the type of sleep-related breathing problem involved. Women deserve particular attention after menopause. Earlier in life, obstructive sleep apnea is diagnosed more often in men. During and after menopause, women's risk rises, and their symptoms may be described as fatigue, insomnia, headaches, mood changes, or frequent awakenings rather than the stereotypical picture of extremely loud snoring and obvious daytime sleepiness. With that background, let us begin with the first sign. Sign 1. A repeated headache that is present on waking. The first sign is not simply having headaches. The pattern matters. A possible sleep-related headache is present when you wake rather than appearing only after several hours of activity. It may be felt across both sides of the head rather than as a one-sided migraine, and some people report that it improves as the morning continues. However, these features are not specific enough to diagnose sleep apnea. Dehydration, teeth grinding, neck strain, migraine, medication effects, caffeine withdrawal, poor sleep, high carbon dioxide levels from other breathing problems, sinus conditions, and many other issues can produce morning discomfort. Why might disturbed breathing contribute? One explanation is that repeated airway obstruction may cause temporary changes in oxygen and carbon dioxide. Blood vessels in and around the brain can respond to these changes. Repeated arousals may also interfere with normal sleep stages, increase pain sensitivity, and leave the nervous system less able to regulate discomfort. But the evidence does not allow us to say that oxygen changes are the cause of every sleep apnea-related headache. The relationship between sleep disorders and headaches may operate in both directions, and the same person can have two separate conditions at the same time. The practical question is not, did I wake with a headache once? It is this happening repeatedly, and what else is happening during my sleep? For 2 weeks, record when the headache begins, how long it lasts, where it is located, how severe it feels, whether you have nausea or visual symptoms, and what improves it. Also, record bedtime, wake time, alcohol intake, overnight awakenings, medication timing, and how rested you feel. Do not repeatedly increase pain medicine without medical advice. Frequent use of some headache medicines can itself contribute to recurring headaches, and treatment decisions become more complicated when several medications or health conditions are involved. A headache diary cannot prove sleep apnea, but it gives your clinician a clearer pattern to evaluate. Sign 2. Loud, irregular snoring or witnessed breathing. Pauses. Snoring is common, and not everyone who snores has obstructive sleep apnea. The more concerning pattern is loud, irregular snoring interrupted by periods of silence, followed by a snort, gasp, or sudden return of breathing. A bed partner may describe it as if the person briefly stops breathing and then starts again. This observation can be extremely useful because the person experiencing the obstruction is usually asleep and may remember nothing. During obstructive sleep apnea, the muscles and tissues supporting the upper airway relax. If the airway becomes narrow, airflow causes vibration, producing snoring. If it closes more completely, the snoring may temporarily stop because little or no air is moving. The brain then triggers a brief arousal, muscle tone increases, and breathing resumes. Government and clinical guidance consistently list loud snoring, witnessed apneas, and breathing that starts and stops as major warning signs that should prompt discussion with a healthcare professional. The distinction is important. Steady, mild snoring without daytime symptoms or witnessed pauses may be primary snoring. Loud, broken snoring accompanied by pauses, gasping, headaches, or impaired daytime functioning is more concerning. If someone shares your home, ask a neutral question rather than a leading one. Have you noticed whether my breathing becomes quiet, pauses, or suddenly restarts during the night? A brief recording may help describe the sound to a clinician, but a phone recording cannot diagnose sleep apnea. It does not reliably measure breathing effort, sleep stage, airflow, oxygen level, heart rhythm, or the number of events per hour. And living alone does not rule sleep apnea out. People who sleep alone may instead notice unexplained awakenings, dry mouth, displaced bedding, sweating, morning headaches, or daytime impairment. Sign 3. Waking while gasping, choking, or fighting for air. The third sign is waking with a sensation of choking, gasping, or needing to take a deep breath. This may happen only occasionally, so it is easy to dismiss. Some people interpret it as a vivid dream, anxiety, acid reflux, or swallowing the wrong way. Those explanations are possible, but repeated awakenings with choking or gasping are also recognized symptoms of obstructive sleep apnea. The sensation can occur when the airway reopens after an obstruction. The person may sit upright, take several large breaths, feel the heart beating quickly, and then fall asleep again. Not every nighttime breathing episode is obstructive sleep apnea. Reflux, asthma, chronic lung disease, panic attacks, nasal blockage, heart conditions, and central sleep apnea can create different forms of nighttime breathlessness. Central sleep apnea is not caused by the throat being physically blocked. It occurs when the brain temporarily fails to send the expected breathing signals. Heart failure, stroke, certain neurological conditions, altitude exposure, and long-term opioid use may increase its likelihood. Obstructive and central events can also occur in the same person. This is one reason self-diagnosis is risky. A sleep study does more than count noises. It helps distinguish among different breathing patterns and indicates how severe the disturbance may be. Breathlessness with chest pain, fainting, bluish lips, severe wheezing, or persistent difficulty breathing while awake requires urgent evaluation rather than waiting for a routine sleep appointment. For less urgent recurring episodes, record when they happen, whether you were sleeping on your back, whether alcohol or a sedating medicine was used that evening, and whether you also experienced reflux, coughing, palpitations, or sweating. Do not stop a prescribed opioid, anxiety medicine, sleeping medicine, or pain medicine suddenly. Instead, ask a clinician or pharmacist whether any of your medicines could worsen nighttime breathing and whether the combination remains appropriate. Sign 4. Sleep that is long enough but never feels restorative. The fourth sign is a contradiction. You may spend 7, 8, or even 9 hours in bed and still feel as though you barely slept. Sleep apnea can repeatedly pull the brain from deeper sleep into lighter sleep. These arousals may last only a few seconds. You may not become fully conscious, yet the normal structure of sleep is disrupted. The result may be unrefreshing sleep, restless sleep, repeated awakenings, or insomnia. Some people fall asleep quickly but wake many times. Others wake too early and cannot return to sleep. Some begin to avoid bedtime because sleep has become frustrating. Women with sleep apnea may be particularly likely to report insomnia, tiredness, headaches, or frequent awakenings rather than classic symptoms. Dry mouth on waking can support this pattern. It may indicate mouth breathing caused by nasal blockage, snoring, or attempts to pull air through a narrowed airway. But dry mouth is also caused by dehydration, diabetes, salivary gland problems, and many commonly used medicines. That is why combinations are more useful than isolated symptoms. Dry mouth plus loud snoring, witnessed pauses, morning headaches, and unrefreshing sleep is more informative than dry mouth alone. A useful step is to keep a sleep diary for at least 1 or 2 weeks. Record when you went to bed, how long you believe it took to fall asleep, how often you remember waking, when you finally got up, and whether you felt restored. Also, record naps, caffeine, alcohol, late meals, congestion, and medication timing. Bring the diary to an appointment rather than trying to remember several weeks of sleep in a few minutes. If this information is helping you recognize a pattern you had dismissed as normal aging, consider sharing it with someone who has also been struggling with unexplained sleep problems. Sign 5. Daytime sleepiness, fatigue, memory problems, or mood changes. The fifth sign is daytime impairment, but it does not always look like falling asleep at the dinner table. Some people experience unmistakable sleepiness. They nod off while reading, watching television, sitting after lunch, riding as a passenger, or waiting in a quiet room. Others say they are not sleepy at all. Instead, they feel physically drained, mentally slow, unmotivated, irritable, forgetful, or unable to concentrate. This difference matters because sleepiness and fatigue are not identical. Sleepiness is the tendency to fall asleep. Fatigue is a lack of physical or mental energy. Sleep apnea may contribute to either, but so can anemia, thyroid disease, depression, chronic pain, heart or lung disease, medication effects, inadequate sleep, and many other conditions. Official guidance warns against using daytime sleepiness alone to decide who should receive further assessment because not everyone with obstructive sleep apnea reports excessive sleepiness. After 60, changes in memory or concentration may be blamed on age, but repeated sleep fragmentation can affect attention, reaction time, learning, decision-making, and emotional regulation. Untreated sleep apnea has also been associated with impaired cognition, reduced quality of life, cardiovascular disease, and motor vehicle crashes. Association does not prove that sleep apnea caused every one of these outcomes in a particular person, but the combination is important enough to discuss. Driving safety is especially important. If you are struggling to stay awake while driving, do not try to overcome it with loud music, open windows, or extra caffeine. Stop driving and arrange another form of transportation. Daytime sleepiness can impair reaction time before a person recognizes how impaired they have become. For an appointment, write down specific examples rather than simply saying, "I am tired." You might report that you fall asleep during television programs, need an unplanned afternoon nap, make mistakes paying bills, lose track of conversations, or feel unusually irritable after what should have been a full night's sleep. Concrete examples help a clinician judge how much the problem is affecting daily life. Sign 6. Waking repeatedly to urinate. The sixth sign is nocturia, waking from sleep to urinate. This is common after 60 and has many possible causes: an enlarged prostate, bladder conditions, diabetes, diuretic medicines, evening fluid intake, leg swelling, heart conditions, and sleep disruption can all contribute. But nocturia is also recognized as a possible feature of obstructive sleep apnea. There are at least two ways the conditions may be connected. First, the urge to urinate may not be what woke you. A breathing event may have caused an arousal, and once awake, you noticed that your bladder was partly full. Second, pressure changes in the chest during obstructed breathing may affect hormones involved in fluid and urine regulation. This mechanism is biologically plausible, but nocturia should never automatically be attributed to sleep apnea. The pattern becomes more meaningful when someone wakes several times nightly and also has loud snoring, witnessed apneas, choking, unrefreshing sleep, or daytime impairment. Keep a simple record of how many times you wake, whether each trip produces a large or small amount of urine, how much fluid you drink in the evening, and when you take diuretics or other medicines. Do not deliberately dehydrate yourself to avoid getting out of bed. Dehydration can cause dizziness, constipation, kidney problems, low blood pressure, and falls. Because nighttime trips to the bathroom increase fall risk, use a clear path, stable footwear, and adequate night lighting. Discuss sudden changes in urination, burning, blood in the urine, severe thirst, leg swelling, or loss of bladder control with a healthcare professional. The myth that causes many cases to be missed. Here is the distinction that changes the interpretation of all 6 signs. You do not have to fit the stereotypical picture of sleep apnea. Obesity is an important risk factor, but people at lower body weights can also have obstructive sleep apnea because of age, jaw structure, tongue size, airway anatomy, nasal obstruction, family history, fluid shifts, or other medical conditions. You also do not have to be male. Women after menopause have increased risk and may present with fatigue, insomnia, mood symptoms, headaches, or frequent awakenings. And you do not have to report overwhelming daytime sleepiness. Some people remain active and alert despite significant sleep-disordered breathing, while others adapt so gradually that they no longer remember what restorative sleep feels like. At the same time, having one risk factor or one symptom does not mean you should be automatically labeled with sleep apnea. The United States Preventive Services Task Force has found insufficient evidence to recommend universal obstructive sleep apnea screening for adults without recognized symptoms, but that recommendation is often misunderstood. It does not apply in the same way to a person who is actively seeking care for snoring, witnessed breathing pauses, choking, unrefreshing sleep, waking headaches, or daytime impairment. Population screening and evaluation of an individual's symptoms are not the same thing. What to ask at your appointment. A useful appointment begins with a clear description rather than a demand for a particular diagnosis. You might say, I have been waking with headaches several mornings each week. I also have unrefreshing sleep and wake to urinate 3 times a night. Could a sleep-related breathing problem be contributing? And should I have a formal sleep evaluation? Bring 5 types of information. First, bring your 2-week sleep and headache diary. Second, bring observations from a partner or family member, especially reports of pauses, gasping, choking, restless movement, or irregular snoring. Third, bring a complete medication list. Include prescription medicines, non-prescription sleep aids, antihistamines, pain medicines, supplements, and alcohol use. Certain medicines used for severe pain, anxiety, or insomnia may worsen breathing or reduce the brain's response to breathing problems. This does not mean they should be stopped abruptly. It means they should be reviewed professionally. Fourth, bring relevant blood pressure readings if you already monitor at home. Do not assume that every morning headache is caused by high blood pressure. Most hypertension produces no obvious symptoms. However, a reading above 180/120 accompanied by chest pain, shortness of breath, weakness, numbness, vision changes, or difficulty speaking is an emergency. Fifth, describe how the symptoms affect safety and independence. Mention falls, driving sleepiness, missed medications, memory errors, or difficulty carrying out normal activities. A clinician may examine your mouth, throat, jaw, neck, nasal passages, heart, and lungs. Depending on the wider picture, blood tests or other investigations may be needed to look for thyroid disease, anemia, diabetes, medication effects, or other causes of fatigue and disturbed sleep. What a sleep test can and cannot show. Sleep apnea should not be diagnosed from symptoms, a smartwatch, a phone application, or automatically scored data alone. A formal sleep study measures aspects of breathing during sleep. Depending on the test, it may record airflow, breathing effort, oxygen level, heart rate, body position, brain waves, eye movements, and muscle activity. A laboratory study, called polysomnography, usually collects the most complete set of information. A home sleep apnea test collects fewer measurements, but may be appropriate for certain uncomplicated adults whose symptoms suggest moderate or severe obstructive sleep apnea. The decision should be based on medical history and clinical evaluation, and the results should be interpreted by appropriately qualified professionals. A negative home test does not always end the investigation. If symptoms remain significant, a clinician may recommend a more comprehensive study. Home testing may be less suitable when someone has substantial heart or lung disease, possible central sleep apnea, neuromuscular disease, long-term opioid use, severe insomnia, or another condition requiring broader monitoring. The result commonly includes an apnea-hypopnea index, or AHI, estimating the number of complete or partial breathing interruptions per hour. But treatment decisions should not depend on one number alone. Symptoms, oxygen patterns, other medical conditions, and the effect on daily life also matter. What happens? If sleep apnea is confirmed, the treatment plan depends on the type and severity of sleep apnea, symptoms, anatomy, other health conditions, and personal preferences. Positive airway pressure therapy is the most common treatment. A PAP device provides air pressure through a mask to help prevent the airway from collapsing. CPAP provides continuous pressure, while other devices adjust pressure in different ways. PAP therapy is supported for adults with obstructive sleep apnea who have excessive sleepiness, impaired sleep-related quality of life, or certain related conditions. It should be started after objective testing and followed by adequate clinical support. Difficulty during the first few nights does not necessarily mean PAP treatment has failed. Mask leakage, nasal congestion, dry mouth, pressure discomfort, skin irritation, or anxiety may often be addressed through mask adjustment, humidification, gradual acclimatization, pressure review, or treatment of nasal symptoms. Do not change pressure settings independently unless your treating service has specifically taught you how and confirmed that adjustment is appropriate. A custom oral appliance that holds the lower jaw forward may be considered for selected people, particularly when CPAP is not tolerated or another approach is clinically suitable. It should be prescribed and fitted by professionals because poor fit may cause jaw discomfort, dental changes, or inadequate treatment. Lifestyle changes may support treatment. These can include reducing alcohol, stopping smoking, improving sleep habits, obtaining regular physical activity, addressing weight when relevant, and sleeping on the side when the apnea is strongly position dependent. These steps are not a guarantee, and they should not be used to delay recommended treatment for clinically significant sleep apnea. Surgery or nerve stimulation devices may be considered in selected cases after specialist assessment. No over-the-counter supplement has been proven to cure obstructive sleep apnea. Stimulants that increase daytime alertness also do not correct repeated airway obstruction during the night. The goal is not simply to stop snoring. It is to improve breathing, restore sleep quality, reduce daytime impairment, and protect the person's ability to think clearly, move safely, drive responsibly, and remain independent. The sixth sign, check. Let us bring the pattern together. The first sign is a recurring headache already present on waking, especially when it repeatedly appears with disturbed sleep. The second is loud or irregular snoring, particularly when another person witnesses silent breathing pauses. The third is waking while choking, gasping, or struggling to take a breath. The fourth is sleep that remains unrefreshing despite enough time in bed, including repeated awakenings or insomnia. The fifth is daytime impairment, sleepiness, unexplained fatigue, poor concentration, memory problems, slowed reactions, or mood changes. The sixth is waking repeatedly to urinate, especially when it occurs alongside the other sleep-related symptoms. One sign alone may have a completely different explanation. Several signs occurring together create a stronger reason to ask for an evaluation. Understanding the pattern is not the same as diagnosing yourself. It is a way to provide better information to the professional who can assess your symptoms, review your medicines, exclude urgent causes, and decide whether a sleep study is appropriate. A morning headache should not be ignored, but it should not automatically create fear. In many cases, the most useful next step is simple. Document the pattern, discuss it clearly, and allow proper testing to separate sleep apnea from the many other possible causes. Recognizing and treating a genuine sleep problem may improve more than the night. It may support clearer thinking, steadier energy, safer movement, and greater confidence during the day. For more evidence-led guidance on protecting sleep, memory, mobility, and independence after 60, subscribe to the channel.